So it's entitled Changing Paradigms in Diagnosis and Treatment, and it's quite an exciting time at the moment. I never thought that as a surgeon I would be getting excited about chemotherapy, but there has been some remarkable advances in the last year or two in the medical side of things. I mean, normally we talk about surgery and curing people, but the change in the treatment for advanced disease has been quite extraordinary and really brings a lot of hope to people in that situation. So we'll just run through a few of the controversial issues. About 5 years ago I was naive enough to think that the debate about early testing would be put to bed fairly soon. It just seems counterintuitive to sit back and not do anything. But you'd have to say it's still raging on as much as it was 10, 15 years ago. And the controversy largely rests around the PSA, prostate-specific antigen, which, as we all know, is prostate-specific but not cancer-specific. In other words, you can have a very high PSA and no cancer at all. You can have a very low PSA and have a bad cancer. So this creates a lot of confusion, and PSA gets a pretty bad press because of that. So just to look at the benefits and risks of testing, there are two schools of thought. In terms of the benefits of PSA testing, before we had it, 70 to 80% of patients had bone cancer at time of diagnosis. And it's hard to believe that anyone would think that that's a good thing. The European randomized study for screening of prostate cancer has shown clearly that screening reduces death rate. The most recent data by 21%, and as time goes on and the follow-up increases, the benefit increases. Early testing reduces the morbidity or the harm of advanced disease. And if we can treat earlier, we can do our procedures better, we can get better functional results and better outcomes. So there are a number of benefits in that respect. PSA, for all its fault, does allow risk stratification. And what we mean by that is that we can divide patients into two groups based on the level of their PSA at any given age. And what we look at is the median level of PSA. If you're above the median at, for argument's sake, 50, then you should be having your PSA done every year because you're at greater risk sometime in the future of developing prostate cancer. If it's less than the median, you can safely wait 5 years. At age 60, if your PSA is less than or equal to 1, your risk of ever getting significant prostate cancer is exceedingly low. In Sweden, they followed patients out 25 years, and they found that the risk of metastasis was 0.5% at 25 years, that's at age 85, and the risk of death at 0.2%. So for all its faults, it does provide a useful way of categorising patients. So the other side of the story, you've probably all heard of the statement, you are more likely to die of prostate cancer than die of it. In fact, just about every public debate or talk on prostate cancer, you hear this. And it's a totally meaningless statement because to lump all prostate cancer into one group just doesn't mean anything. As it reads, it's a correct statement, but of course we have two different types of prostate cancer, little low-grade insignificant cancers that are never going to cause a problem, and the aggressive cancers. And lumping them all together and say you're not going to die from prostate cancer is just, it's just dishonest, really. I mean, but unfortunately, just about everybody I know has heard that statement at least once. And I was talking to a patient at a social function recently who had a radical prostatectomy, and he brought it up. He said, well, 70% of my friends keep talking about oh no, I won't bother getting tested because I'll die of something else. And it's just out there in the community, and it's probably done more harm than any other thing, I think, in the prostate cancer debate. The other issues, because prostate cancer is a slow-growing cancer, it takes quite a long time to run into trouble. So the converse of that is, if you do nothing, then it'll seem good for maybe 5, 10, 15 years. So if you support the view that you shouldn't test, it takes a long time to prove you're wrong. According to the people who are against it, it's only beneficial in a small percentage of patients, and there's always the risk of some sort of complication from having a biopsy, getting diagnosed and being treated. The other factor, of course, is that we're now living longer and we're healthier at older age than we used to be. So what that means is that even though it might be a slow-growing cancer, if you live long enough, then it's more likely to catch up with you. And I think in today's age, prostate cancer is much more relevant than these sort of ideas would suggest. The principal investigator, Fritz Schroeder, for the European study stated, in the present situation, early diagnosis cannot be refused to men who are well informed and request to be tested. But this does happen even in this day and age. The College of GPs recommendation currently is don't talk to patients about prostate cancer. If they bring it up, that's okay, but don't bring it up. And it just seems a shame that a lot of patients are going to miss the opportunity for a cure on the basis of that. So obviously you have to find a balance. We don't want to over-diagnose and over-treat, but we also want to avoid the problems of prostate cancer. My own view is that it's not up to any doctor to advocate for or against testing. The patient really has to make the decision. So it's wrong for me to say to someone, this is what you must do. You have to explain the benefits and the risks. And if someone wants to be proactive about their health, they'll probably elect to do it. If people are worried about the risks of treatment, then they may elect to do otherwise. But to actually come out and say you should or shouldn't do this, I think is not appropriate. When it comes to diagnosis, the old diagnostic paradigm was we do a PSA, and that's still a good test because it does alert you to the presence of prostate cancer. We do a rectal examination. That's also somewhat controversial. There are a number of authorities who would say there's no statistical benefit to doing it. But that's also crazy because some patients can only be diagnosed on rectal examination. And then we would do a transrectal ultrasound and biopsy. And I think it was the transrectal ultrasound and biopsy that was the test that should get the criticism. You're probably familiar with this, the probes in the rectum, and you image the prostate and the biopsy needle goes through the rectal wall into the prostate. This is a typical ultrasound picture of a prostate, and you can see it's very homogeneous. There's not a lot of anatomical detail, and unfortunately you don't usually see the cancer unless it's very advanced. When you compare the image that you get with ultrasound and a good quality MRI, you can see they're just chalk and cheese. The two zones of the prostate are clearly separated there. That's the outer zone where you're most likely to get cancers, and the inner zone with all the little BPH nodules show up very nicely. You can barely see the difference between the zones. Cancer usually shows up as a dark area in the peripheral zone, but you can also see it in the central zone. So the problem with transrectal ultrasound and biopsy is there are three problems. This is a schematic view of the prostate. This is the needle coming in posteriorly from the rectum. And the first problem is that there might be a big tumour in this side of the prostate, which you don't even hit. The tumour is depicted by brown, with red being a high-grade component. Often there's a more aggressive part of it and a less aggressive part of it. So first situation that goes wrong with the transrectal ultrasound and biopsy is that you might miss it altogether. The second is that you might just hit one little spot of low-grade cancer and you don't know whether you're dealing with just that or whether it may be a sign that there's something else in the prostate. And the third situation is if you have a tumour, you may just hit the edge of it and miss the high-grade tumour, and then you undergrade the tumour, so you think you've got an insignificant cancer, but you haven't. So these were, in essence, the problems with transrectal ultrasound. So what we've always needed, and we've been looking for this for a long time, is a non-invasive test that can reliably detect the significant cancers. And they are chalk and cheese. You have cancers that will never cause a problem. You have very aggressive cancers. You have some that are in between. But we really have struggled for years and years with transrectal ultrasound and biopsy. An MRI, I think, has been the game changer because in clinical practice, we would see so many men who may have an enlarged prostate but also an elevated PSA. So is the PSA up because of the enlargement and benign disease, or is it cancer, and should we do a biopsy or not? And we generally would do a biopsy because we didn't want to run the risk of missing a significant cancer. With MRI, it is very good at detecting significant cancer, and if it says there's something there, it's right about 90 to 95% of the time. If the MRI says that everything's okay, it's right about 85% of the time. But there are some provisos here. It's a test that has to be done well. You have to have a good, experienced unit with good technicians and radiologists who can accurately report it, which we fortunately have at the SAN. And there are cost issues. There is no Medicare item number at the moment. We're working on that, but it may take some time before that comes through. So at the moment, not everyone can afford the $650 for a good MRI. So this demonstrates this is the anatomical study called T2. You can see the two zones of the prostate. This is the central zone, and there's a dark area up here which alerts us to the possibility of a cancer. On the what's called diffusion phase, which looks at cell movement, cells that are packed tightly together don't give off a signal and they look black. Cells that are not packed tightly together give off a signal and look white. And the blacker it is, the more likely it is to be a cancer and more likely to be a high-grade cancer. This particular patient had, I think, 5 or 6 biopsies by myself over a 10-year period, and the PSA just kept going up and we never hit the target. And that's because of what we saw on the schematic diagram. The needle was getting so far in here, but we never quite got to where the cancer was. So within a month of MRI coming in, he had a diagnosis of cancer, and then he went on to have treatment.
Mr. Hahn?
Oh yes, yeah. So in his situation, instead of doing a transrectal biopsy, we did a transperineal biopsy. So the transrectal, if you remember, the probe was in the rectum, and you angled it up so that the needle would go into the prostate that way, making it difficult to get at that area there. With the transperineal biopsies, we put through a grid. The needles go through here, and we can select a grid space up there, and we can hit even the most anterior tumours. So the MRI allows us to target tumours, and it allows us to get to parts of the prostate that might be difficult to get to with the transrectal approach. One being the very anterior area there, and another one being the apex in this area. It's almost impossible to hit that coming from the rectum. So this is another patient. That's the central zone, which looks darker, the outer zone, which looks lighter, and there you can see the dark area, which is going out towards the capsule. You can almost predict that that might be invading into the capsule just by looking at that. And the diffusion study shows a very black, dark area, which is the high-grade cancer. So this is a cancer that's going to cause problems. So the place of MRI is still being debated. It is very good for localising the tumours, and the benefit of that is that if we do biopsies based on MRI, we're less likely to miss the target. So we don't get the false negative biopsy, which happened maybe in about 20–25% of cases previously. Patients have a biopsy, it comes back negative, everyone's happy, the PSA goes up, and 2 years later you may diagnose a cancer, and so you lose a couple of years before you can start treatment. It's good for planning treatment, as we can see sometimes when it's close to the edge of the prostate. If you're operating or giving radiotherapy for that matter, you can plan your treatment around that. And it is good for the borderline case, as we mentioned before. If someone's got a very large prostate, which you would expect to push the PSA up, and you're not sure whether to do a biopsy, it can help. And the other borderline situation is the older patient. I have a lot of patients 75 to 80 years who are perfectly fit and healthy and obviously going to live for another 10 years or more, and they come in with a borderline situation. We don't really want to do a lot of biopsies at that age group, but we don't want to miss important cancers. So if you do an MRI, you know that you've got about a 90% chance of picking up a serious cancer just with the MRI alone, just in one fell swoop.
Can I ask if that 90% applies equally to 3 Tesla and 1.5 Tesla machines?
Yes, if you talk to people in experienced units, there really isn't a great deal of difference between the 3T and the 1.5T overall in terms of what you can achieve. Some of the original pioneers in Lille in France, Dr. Puch and Villas, used 1.5 machine up until about 1 or 2 years ago. And there's been recent studies also which have shown that there's been really very little difference in the performance. The 3T gives you better diffusion pictures. That's the cell movement phase. But overall, you can manage quite well with a 1.5 machine. And the other role for MRI is in active surveillance. If we decide not to treat someone because we think they don't need it, it's important to do an MRI to make sure we're not sitting on an obviously aggressive tumour. And that's been incorporated into most active surveillance protocols now. So what we plan to do now is a PSA, which sets the ball rolling, a rectal examination as before. We put the MRI in there so that we're able to reassess the patient depending on their age, what health issues they have, what their PSA is, and then you can make a decision. You may or may not want to biopsy the patient. If you do biopsy the patient, you've got a target in most cases to aim at, and you can also determine whether it might be better to do the procedure transrectally or transperineally. The transperineal approach has the added bonus that it's highly unlikely you'll get any infection as you may do with the transrectal approach. Gene testing is a new area which is going to help in diagnosis and all aspects, selecting patients for treatment, but is not quite ready for widespread use at this stage. So when we go on to treatment, there are a lot of different treatments out there. There's a lot of information on the internet, and a lot of patients become totally bewildered when they start researching this. And it can be difficult to know what you should do. So many different opinions, and you get different advice from different people. So we'll try to straighten that out. So there's really a number of different situations. Localised cancer, the first decision is whether we're going to treat actively or put on surveillance. That depends on a number of factors, and there are well sort of established protocols for that. and surgery or radiotherapy would be the curative treatments that we'd recommend. Locally advanced treatment generally means that the cancer is still in the prostate or perhaps invading through into surrounding tissue, and it's nearly always an aggressive tumour that does that. Oligometastatic disease, we'll talk about a bit more in a moment, basically means that there are a small number of metastases that are clinically proven, and then the question is whether you should be treating those with curative intent. When we get on to metastatic disease, the first category is patients who have never had any hormone treatment, and the second category is what we call metastatic hormone insensitive or castrate resistant prostate cancer. So they're the sort of categories that we would be looking at. Before we start, we have to make sure that we're not dealing with one of these pussycats. This is a patient who was only young, he's only 53, had a fairly rapidly rising and high PSA. He had a biopsy done. We found one spot of, or one focus of Gleason 6 disease, low-grade prostate cancer. And this was in the days before MRI, and he was not comfortable with being on a surveillance program. We did our best to convince him that he should wait 6 months and have another biopsy and watch the PSA, but in the end he elected to have surgery. And this is the diagram the pathologist gives us after the operation. And there's one little spot of low-grade cancer sitting there. And it's not a good feeling when you operate on someone and you get a report like that, because you know this was something that was never going to cause him a problem. But this has largely been avoided by MRI. We don't often have that situation now.
Why is the PSA so high?
The problem with PSA, it goes up for all sorts of reasons. Anything that's happening in the prostate will make it go up. But we have quite a few patients where the PSA goes up and we can't find a cause for it. And it can be 10, 15, 20. Some patients just have a high PSA and there's no explanation. They're fairly rare, but at least in a patient like this, if we had an MRI, we'd have a greater confidence that we weren't missing a serious cancer if we put him on surveillance. Back in those days, I'd had patients with exactly the same situation who had a bad cancer that was invading all sorts of areas. So that was the worry in those days. Once you had the diagnosis, you just didn't know for certain what you were sitting on. So with locally advanced, this is the more aggressive cancer without any obvious distant metastases. What we used to do would be to remove the prostate. If we thought it was curable, we wouldn't normally be operating if we thought it was outside the prostate and we couldn't cure it. Or we'd give radiotherapy as the first treatment. And then, if surgery was used, we'd quite often have to use post-operative radiotherapy if it wasn't totally removed and the PSA was still elevated. And after that, if the PSA started to go up, what we would do is wait for a while before we started hormone treatment. So we might wait somewhat empirically till the PSA reached 5 or 10. Then we would start hormone treatment or androgen deprivation therapy, testosterone, taking the testosterone away with hormone injections usually. And we'd do that at some stage, and the results were pretty good. The PSA would come down usually to very low levels, stay down for quite some time, and patients would do quite well considering that they had obviously metastatic and extensive disease. And then if and when the cancer was no longer responding to the hormones, then we would start thinking about other treatments. The University of San Francisco had a score called a Capra score, which was from 0 to 10. And it was based on these parameters: the PSA, the Gleason score, clinical stage, in other words, how it feels on the examination, the percentage of positive biopsy cores, and the age of the patient. So the maximum score would be 10 if you had a PSA greater than 30, you had Gleason 4 plus 5 or similar. If there was a palpable nodule, if you had more than a third of the cores containing cancer, and if you were over 50. So this gave us a risk score from 0 to 10. And this sort of demonstrates what was going on in the United States. This is back in 1996, the Capture data, which is a big database in the States. And these are the categories of risk. So these are the low risk categories. And you can see that these are really very favourable cancers that probably didn't need treating at all. Up here we have the options. That's no treatment, which they were calling watchful waiting in those days, radical surgery, brachytherapy, external radiotherapy, cryosurgery, which was popular in the States, and primary androgen deprivation or hormonal treatment. So what was happening is that all these cases here, the vast majority of them were getting an operation they didn't need, and the observation was maybe 5%. Now in the States, surveillance has always been lower than over here. Currently it runs at about 19-20%, and it is going up, whereas in Australia it might be 30 or 40% for surveillance. But bear in mind this was some years ago, but even so, in the States they still don't put patients on active surveillance as much as we do here. And the other thing about this is these are the really bad cancers with very poor outlook, and these are the ones that really needed to have their prostate out. There's a lot of data now to show that that's what is going to give the best outcome for the very bad cancers, even if there is some spread beyond the prostate. So everything was upside down back then in the States, and it was similar here, but not to quite the same extent. So I just mentioned that getting the prostate out is good for bad cancers, and there are a number of reasons for that. Some patients actually have an obstruction from their BPH as well as the cancer, so it's going to deal with both problems at the same sitting. And if you can control the tumour locally, even if there are metastases and widespread disease, patients have a better quality of life if they don't have to have problems with obstruction and having repeated operations for blockages from local cancer regrowth. There's a lot of evidence that metastases keep occurring, and if you've still got the primary tumour there, unless it is being completely eradicated by radiotherapy, it's going to continue producing more metastases. And there's also evidence now from Melbourne that metastases can feed the primary tumour as well. So if you have the primary tumour still there, you can have metastases feeding the primary tumour and also feeding other metastases. So there is a focus now on trying to reduce the tumour burden to give a better long-term survival in patients with advanced disease. There is a precedent in other cancers where taking the primary tumour out improves the survival. If you have radiotherapy and it doesn't work, then some patients, it's a fairly rare situation, may have to have what's called a salvage prostatectomy, which means that you have to operate in fairly unfavourable circumstances. The tissue planes are scarred, you can damage the rectum, things don't heal well, and there's a very high risk of incontinence. And there are a number of studies that show a distinct survival benefit for surgery over radiotherapy in this situation. I put that down the bottom because there is some debate about this. I mean, obviously, you have to look at how these studies have been run and how they've accrued the patients. And there are some people who would cast some doubt over that. But I think that there are a lot of studies that do show a survival benefit for surgery in the locally advanced aggressive tumours. This is an interesting study done in Germany, and they looked at men who had early bone metastases, and before they started the hormone treatment, they did a radical prostatectomy in half of the patients. Well, they had hormone treatment for 6 months, and then they had the radical prostatectomy. So when they were starting their treatment, half the patients just had hormone treatment, and half had 6 months of hormones and then the prostatectomy. And they found that there were viable cancer cells despite having the hormone treatment in the patients who had their prostate out. When they took the prostate out, every prostate had viable cancer cells. And there was also a significant survival advantage for having your prostate out. So that's in patients who already have demonstrated metastatic disease. We can demonstrate a survival advantage. There's been a number of recent developments that have helped a lot. PET scanning is probably the hottest topic now in prostate cancer. You can pick up isolated metastases in all sorts of places, and the radiotherapists can treat those with stereotactic radiotherapy. We are more aware now of what the risks of hormone treatment are, and I think there is generally a trend to try to delay using hormone treatment because of that. We have a lot of improved medical treatments, and the earlier and more aggressive medical therapies now than there used to be. We used to just sit back and wait until the cancers became hormone insensitive, and then we might start afresh with all these other treatments. And of course you're dealing then with more advanced disease, and not surprisingly you may not get such a good result. So for locally advanced treatment, I think that a prostatectomy is a good thing to do if it's appropriate. We're not going to operate on people who aren't fit for surgery or have a lot of other medical issues. So you're not going to be operating on everyone, but if it's appropriate from a medical point of view, I think there's a lot of evidence to suggest that that's a good thing to do. We have better tumour localisation with the PET scans. Sometimes after a radical prostatectomy, if the PSA is up, it's difficult to know where the tumour is. Now we can, in a lot of cases, localise it with a PET scan. We use multimodal therapy, and there is a thought that we should be considering early chemotherapy rather than sitting back and waiting until the patient's been on hormone treatment for years and the cancer's progressing. Perhaps we should be using chemotherapy earlier. That's highly controversial, and there's no data to support that. But I think there is a bit of a groundswell of interest anyway in doing that. In the past, chemotherapy was reserved for the cases where everything else had failed because we were worried about the toxicity and the side effects of chemotherapy. That's less of an issue now than it used to be. And I think that a lot of people feel that delaying hormone treatment is a good thing. If we don't have to give hormone treatment, which targets the whole body, better to treat locally and give hormone treatment later if necessary. Oligometastatic disease is a term that's been around for a few years now, and it means just a limited number of clinically detectable metastases. And it could be a transitional state between localised and widespread metastatic disease. It's possible that if you treat oligometastatic disease, you may get an outright cure if it's just that. More likely, you're just going to reduce the disease burden, and other metastases will come up later. But I think there is the principle of treating the disease if you know it's there and getting rid of it is a good one. I think there's certainly experimental evidence to suggest that the long-term outcome is going to be better if you keep on top of it rather than just waiting for it to progress. The treatment of metastatic disease with hormonal treatment is fairly standard, either with the androgen deprivation treatments or anti-androgen tablets. But androgen deprivation does have some side effects, as the metabolic and cardiac effects, weight gain, insulin resistance. Musculoskeletal, you get osteopenia, you get loss of muscle mass, sexual function issues. And I think, quite importantly, the cognitive depression, motivation, lethargy, those sort of symptoms are also a factor. I had a used car salesman who complained that when he's on his Zoladex, he didn't quite have the same fire to sort of drive the price up when he was dealing with a customer, and he just couldn't quite achieve the same results he had before he went onto the hormones. So once the disease is resistant to hormonal therapy, then the good news is there's a whole host of new agents that are getting very promising results. There's the androgen receptor agents such as abiraterone and enzalutamide. Chemotherapy, doxytaxel is now getting some very promising results. There's immunotherapy and bone targeting with radio pharmaceuticals. So there's all sorts of things that are there. 2 years ago, the Chartered trial was a landmark study. It was presented at the American meeting. These are the patients who were going on to hormone treatments, almost 800 patients in two groups. And they were about to start hormone treatment, and half the patients got just hormones and half got doxytaxel, which is chemotherapy. And they had low volume disease and high volume disease. And particularly in the high volume disease, there was a dramatic survival benefit for patients who had the chemotherapy as opposed to the patients who just had the hormone treatment. And this is the first time for many years that we had a very positive outcome from chemotherapy, and it's really rejuvenated the profession to think that there may be benefit in using chemotherapy earlier in the disease process rather than just waiting until they'd been on hormones for 5 years and the disease wasn't responding. So I think it's a very exciting development. I never thought I'd say that about chemotherapy. It's always been something that was a little bit of, away from surgery. And at the prostate cancer meeting in Cairns this year, for the first time ever, there was an oncologist who was talking about having an endpoint in his study for 0 PSA. So instead of looking at how long you survived before you might have had a recurrence or some sort of other problem, their endpoint was, for the study they were doing, was a 0 PSA, and this is a total change in thinking in oncology. I think they're now aggressively treating metastatic disease and really raising the bar quite significantly. So I'll just finish off with a case. Patient I operated on 3 years ago. He was 76 at the time. He came with what you'd call locally advanced high-grade disease. You could feel the cancer quite obviously. He was almost certainly not curable at that stage, and the first decision was what treatment. And I actually suggested he should have radiotherapy because of his age. He was 76. He came to Australia 50 years ago from Croatia. He worked on the Snowy Mountains scheme. He was a big, tall, strapping fellow. He looked 20 years younger. He'd never had a day in hospital in his life. He said, "No, I want to have it out." And I sort of had an inclination that was probably quite a good treatment for his cancer, but we just weren't quite in the sort of, we hadn't quite sort of come to grips with operating on patients where you thought were incurable, particularly at that age. But that's what we did. He had an old-fashioned open radical prostatectomy, and he flew through that. His urinary control was perfect, and he did quite well, though his PSA didn't come down to 0, so we gave some adjuvant radiotherapy to the prostate bed. And again, he tolerated that very well, but this was 2 years ago. But the PSA still didn't come down, and then it started to go up again. So we did a PET scan. And he's had radiation to the prostate bed and the pelvic lymph nodes, but he's got some more lymph nodes higher up. There's 3 or 4 areas with where the PET scan suggests there may be some metastases. All these other scans were clear. So this is a patient with what you'd call oligo metastatic disease, and we discussed his case at our meeting, and the feeling was that he could have radiotherapy to those nodes, and that's what he's going to do. Now, we don't know what's going to happen. It's quite possible that he's going to have other disease, but the concept of getting rid of the disease, if we know it's there, and delaying the onset of hormonal therapy is very attractive. And there's certainly data coming out suggesting that this approach confers a survival advantage on patients. So when you consider this patient at the age of 76, in the past he would have had either radiotherapy and hormonal therapy, or hormonal therapy first, and even at this stage he probably would have been getting a much higher PSA and be in a worse situation. So if we can keep him off hormonal therapy for a few more years, then that would be, I think, worthwhile. But it's all new, it's all relatively experimental. We don't quite know where it's heading, but I think the potential is certainly there. So with the MRI in particular, we've got better diagnosis. The treatments are improving, and we are now prepared to operate on patients who probably have metastatic disease. And we're delaying hormonal treatment if we can, and when hormone treatment's given and you fail hormone treatment, then there are a whole host of new treatments coming in that you can then use. So for the patient, this means that even in a fairly grim situation, you're looking a long way out to the future, and I think that in 20 years' time we'll look back and wonder why we weren't doing it before.